in the same way that a skyscraper over the New York City skylines was built on exact blueprints. A precision advanced orthogonal spinal correction can only be obtained from accurate analysis from properly positioned X-rays. So welcome to the Advanced Orthogonal X-ray Positioning course. Our X-rays are taken on a 10 by 12 inch film at a source image distance of 46 inches. The patient is seated in a movable chair in an upright, neutral posture with their hard palate level. So here you can see the X-ray tube where the X-rays are produced, sent to the film or cassette capturing inside the bucky. That distance is 46 inches. The patient is seated in this movable chair. This is called a C-arm X-ray unit, as you're viewing here, because the tube and the bucky are connected by this arm, forming a C. The first X-ray we'll be viewing is the sagittal film and discussing its positioning. This is taken down the x-axis from the side. The tube is set at 0 degrees and the bucky is 90 degrees to the tube. The patient is positioned with their shoulder touching the bucky, and we're going to remove head rotation looking at the lateral canthus of the patient. Now this will be the eye orbit to side of the head viewed on both sides of the patient, and we're going to rotate the chair while viewing the patient from directly in front of them until those distances are equal. We're also going to accommodate for any patient head tilt by tilting the tube and bucky to reflect the patient's head tilt. If we're looking at the anatomy of the jaw and skull, you can see here how when looking at the side, if a patient was being x-rayed directly through the side, both the left and the right jaw lines would superimpose each other on the posterior borders. However, if the patient was left rotated, where this side of the canthus and this side are not symmetrical, then the jaws would not be symmetrical on the posterior borders. So as we put the patient in here, and you look at the distance from the eye canthus on the left-hand side of the patient and on the right-hand side of the patient, when you see that distance and you see that they are not symmetrical, if you took an x-ray directly through the side of this patient, this jaw on her right side would be more anterior than the jaw on her left side, and you would see two posterior jaw lines on the film. When we accommodate for head tilt, we will be tilting the tube until the central ray is passing through the head tilt on the exact angle it is sitting. We'll be sure to review this process in the hands-on practical week 3. But when we look at the head tilt and notice that this jaw line on the left side of the patient and on the right side of the patient, if there's head tilt and we took the x-ray directly through the side without accommodating for head tilt, then the patient's right jaw would be more inferior than the left jaw. And when we looked at the side, we would see the two bottoms of the jaw not superimposing. Thus, we can see an x-ray taken through the side of this patient with head tilt gives us two inferior rami that are offset. And this would mean we accidentally did not accommodate for head tilt in the positioning for this view. In both this case and in the case where we left rotation on the film, the x-ray should be retaken in order to attempt to get this jaw line symmetrical. In quality control of the sagittal view, we must look and see that the superior and inferior rami of the mandible are superimposed on the film. If there's more than 6 millimeters of rotation or lateral flexion between these jaw lines, this film should be retaken. We need to have the facial features visible on the film, and the hard palate needs to be level and clear. We also would want to see all the way down to C6, C7 for any pathological evaluations. When looking at our next x-ray, we're going to be viewing the horizontal film, which is viewed from the top down the y-axis. When starting the horizontal x-ray, we're going to preset the x-ray tube at 50 degrees and preset the bucky at 30 degrees. We're then going to position the patient's chin just over top of the crosshairs on the Bucky, and we're going to aim our central ray going through the crown of the head to the center of the Bucky. We're going to remove head rotation using the chair, looking at the angle of the mandible and the Bucky from side to side for symmetry. If it's not symmetrical, we'll be rotating the chair to accommodate for that. We're also going to be removing the patient's head tilt, not by pushing on their head, but by tilting them at their torso. We will then put head clamps over the parietal bones. So when assessing for rotation, if we view that the angle formed between the patient's jaw and the Bucky is more acute on one side than the other, that means this patient's right cheek is closer to the Bucky than their left cheek. So we would back the patient away slightly to get their chin off the film. We would rotate the chair until these angles were symmetrical, and then we would lean them back forward to put their chin on the Bucky. If we were looking at the X-ray and there was rotation, we would see that the frontal groove and the IOP would not be vertically centered on the film, that there would be rotation. So how would we reduce the rotation? Once again, back the patient off the film, rotate the chair until the angles are symmetrical, and then position the patient again with their chin on the center of the film. When looking through the top of the patient for horizontal tilt, if there is head tilt occurring on this film, the two main ways we assess for that. One, we put our fingertips underneath the patient's mastoid, point our fingers towards each other, and see if the line on the bottom of the mastoids that our fingers are representing is parallel to the central horizontal line on the Bucky. If they are not level with the center line of the Bucky, then that means there is head tilt on this patient's setup. A second way of assessing it is to look in the mirror and see if this vertical line is passing through both the glabella and the nose and the frenulum. If not, that would also indicate that there is lateral head tilt. To correct for this, we would back the patient away from the film slightly, slide the chair towards the side of head tilt, then bend the patient at the waist back towards center, and reposition their chin upon the center of the film once again. At that point, you would recheck with your fingertips underneath the mastoids and recheck your central line to see if the glabella and the nose and the frenulum are all in line, and that would let you know that you have accommodated for the head tilt. If you're looking at the X-ray, you would look at the spacing where the zygomatics and the side of the skull, that distance from side to side, we would want symmetrical. If they are not symmetrical, that means there was head tilt on this patient's setup. For the horizontal view to be accepted, we need the entire skull to show up on the film, with the frontal groove and the IOP vertically centered. We would want less than 2 millimeters of difference in the zygomatics to side of skull from side to side, and the atlas would show up in the posterior third of this film. Now, as we discussed that, this would be approximately halfway. So here would be 1/3, here would be the posterior third. The atlas typically sits right at that line of the middle and posterior third. One other little point of interest is that the back of the mandible here and the occiput, there is a window between those two through which we can most clearly see the atlas vertebrae. If the patient is not extended enough on the Bucky, then that window will close together. So the distance between the mandible and occiput will approximate, and it will close this window until the atlas starts to get superimposed by other bone sources. That makes it difficult to study. So if you're not able to see the atlas because of the other bone structures in the way, you need to extend the patient up onto the Bucky further. And that will open up your window to see the atlas. The next X-ray we'll talk about taking is the axial view. It's taken through the front down the z-axis. We will have measured the sagittal film to assess the axial angle, which will set the axial X-ray on, and the atlas sagittal plane line to assess which angle to take the frontal film on. So in starting for the axial X-ray, we're going to set the X-ray tube at the angle that we obtained from the sagittal view called the axial angle. Now that angle is the plane from which you can best view the C2 surface. So as we set the X-ray tube to that angle, leaving the bucky 90 degrees to the tube, we're going to position the patient with their back touching the bucky. We're going to do the same assessment of head rotation, looking at the lateral canthus of the eyes, and using the chair to unrotate the patient until the lateral canthus widths match on both sides. We're not going to take out head tilt, and typically the patient's mouth will be open for this view. Our goal on this is to be able to visibly see the superior surface of C2. So in quality control, we must be able to see that surface with no teeth or occiput superimposing over it. We ideally would like to have no rotation on this film either, because we're going to be using this film to cross-reference the location of the C2 spinous, so we can take that information to our frontal film for analysis if we need help seeing the spinous on the frontal film. And the last X-ray we take is called the frontal film. It's taken from the front down the z-axis also. The first thing we do is set the X-ray tube to match the atlas sagittal plane line obtained from the sagittal view. We then will tilt the bucky to match the patient's posture, and then we'll back the patient up until their back and occiput are touching the bucky. We can pull them slightly away if we've looked at the lateral canthus and found them not symmetrical. We can pull the patient slightly away to rotate the chair till we get the lateral canthus widths symmetrical, and that will have removed head rotation. We will not be removing head tilt on this film, and we will use centering head clamps to stabilize the patient in the center of the film. And those head clamps will be placed over the C1 location. If you look at this patient positioning, and we were to observe that the canthus is more narrowed on one side than the other, then if we were to look at the actual film, we could see the canthus is more narrowed on one side than the other. So if you did your setup as well as you possibly could, and then you looked at the X-ray film and you saw this observation, where the widths were not symmetrical, if you observed the frontal bone more dense than the temporal bone, and this line coming down and joining the eye orbit, forming that little X right here and right here, and if the width from there to the side of the film was not symmetrical, you would realize from your film that the patient had rotation left in their positioning. And the distance would show up if we would have paid attention here. So our primary reference of rotation on the film is looking at eye orbits to the side of the head, the lateral canthus, both sides. Our secondary reference is where the zygomatic cheekbone intersects the mastoid. So you can see in this example where this patient was still rotated in their setup that the zygomatic overlays the mastoid very far to the side of it. However, on this side it runs into it. This is not symmetrical. That would indicate there is also rotation. Our third reference is looking at the sides of the nasal cavity compared to the sides of the lateral mass. Those also should be symmetrical. However, this is our third reference and least important reference, because if you look up here, the lateral canthus is a skull-to-skull relationship for assessing rotation. The zygomatic and mastoid is a skull-to-skull relationship assessing for rotation. And therefore, because it's a skull-to-skull relationship, it's more accurate. The third reference here is the nasal cavity to the C1 vertebrae. And there are numerous things that can actually throw off that symmetry. It can be used as a third reference, but make sure you use lateral canthus as your primary with zygomatic mastoid relationship as your secondary. When we're doing quality control assessments of the actual film and looking from the eye orbits to the side, we need less than 2 millimeters of rotation. We should say less than 2 millimeters of inconsistency from side to side. We'd like to see the zygomatics intersecting the mastoids the same. And we do want to be able to see the condyles, the entire atlas lateral mass, the C7, and the posterior arch of the atlas needs to be flat or slightly frowning. That can be sustained if your X-ray tube setting was at the atlas sagittal plane angle obtained from your sagittal film. If you have a low arch, that's an unacceptable film, and you would need to retake this X-ray. If you had more than 2 millimeters of head rotation, you would also need to retake this X-ray. So be certain that you get properly positioned X-rays that you can study and mathematically conclude the exact angle for correction. And by doing so, you've put yourself far ahead in your goal of rendering a complete correction that will hold and change this patient's life forever.